Good evening, everyone. Um, it gives me a great pleasure to welcome you all to this month's continuous professional development program organized by the Sri Lanka College of Specialist Family Physicians. Today, we are honored to have Professor Kavinda Dayasiri, consultant pediatrician and professor in pediatrics at the Faculty of Medicine, University of Kelaniya. Sir, we are truly privileged to benefit from your expertise today. And today's topic would be pediatric poisoning essentials for family physicians. And it is highly relevant to our practice because as family physicians, we are often the first point of contact for emergencies, including conditions like pediatric poisoning also sometimes. So I think you would make this session interactive and this would be an insightful session for all of us. And before that, before we begin, I would like to remind some housekeeping rules. Please make sure to keep your microphones muted and rename yourselves with a Zoom name similar to that should appear in the participation certificate of yours. And towards the end of the lecture, a link will be shared in the chat box, and please fill it because filling that Google form and attending the lecture for 1 hour is essential to obtain the CPD certificate. And if you have any questions, kindly type them in the chat box and they will be addressed later by Professor Kavinda. So with that, I hand over the session to our resource person, Professor Kavinda Dayasiri. Thank you. Thank you all.
Thank you very much for your kind words of introduction. And it's also a pleasure for me to deliver this talk to you. And I hope this will be useful for your practice as well as if anybody is doing exams, for your exams. So let me begin with the presentation. And if you have any questions, please do ask at the end of the presentation. I'm very happy to answer if you have any questions. So to begin with, so I know that all of you are family physicians or are going to be family physicians in the future. And family physicians play a very crucial role in managing pediatric poisoning cases, children, because they are the first point of contact, especially when we have this DP system very well established. Sometimes it may be difficult, for a parent to get in touch with the pediatrician at once, unless you go for a private sector, right? So it's very good that general practitioners as well as family specialists be aware in depth about common presentations where children present after an event of poisoning, and the responsibilities can span from prevention to early recognition to management as well as follow-up after an event happens, especially in the event of a deliberate poisoning where a child needs to be followed up, especially from the psychological point of view. And poisoning in children is different to poisoning that we see in adults because the patient is a child, and this poisoning event is often unwitnessed or unintentional. Therefore, parents may not present a clear history. Often they are not sure about the exact dose or the time of ingestion because the child, some children are non-verbal, some children may not take an interest in telling you the truth because they do it as part of the exploratory behavior. And also the circumstance of poisoning can change with age. As you know, accidental poisoning is quite common in young children, whereas as children grow, deliberate self-harm and deliberate self-poisoning become more common, continuing with the practice with habits of the adults, behavior in adults. And also the toxicokinetics can change with the weight and age of the child. Unlike adult, where we take the standard weight as 50 kilos, and pharmacokinetics are more or less same unless they have comorbidities. But in children, depending on the age, they can be quite variable. And certain injections may have safeguarding concerns. For example, this can happen as an act of negligence, or sometimes parent might seek medical attention by doing certain things intentionally, which is known as which is also known as Munchausen syndrome by proxy. And also, it's also important to know, unlike in adults, in young infants or infants, if they ingest a couple of tablets of certain tablet types, that can result in a death because of their lower body weight and the risk for ingesting a very high toxic dose. Therefore, as clinicians, we should select the worst case scenario in an event of poisoning, and in the event where there is no clear history is available, we have to anticipate the worst and then plan our management for that scenario. And if you look at the global epidemiology, accidental poisoning is a global health issue among children and adolescents. And you might not believe it results in approximately 45,000 deaths every year around the world. And even in our country, we see a notable number of deaths when it comes to teenagers committing deliberate self-poisoning, which also are also included in this pediatric poisonings. And therefore, it continues, this problem continues to be a significant cause of morbidity and mortality. In our context, in Sri Lankan context, over the years, we have seen in children, the kerosene oil had been the most common poison children used to ingest. But now the circumstances are changing. We are moving from that era to more modern era where pharmaceutical poisons are seen increasingly more commonly compared to kerosene oil. But still, if you go into the rural territories of the country, you see a notable number of children presenting after ingestion of kerosene oil. And paracetamol is the most common, like accounts for nearly 50%, 60% of the total ingestions when it comes to teenagers. We recently did a study of around 2,400 admissions in just 6 teaching hospitals across the country over a period of 2 years. And in that study, paracetamol accounted for over 50% of all presentations in adolescents. So it continues to be the most common ingestion seen among teenagers. And over the years, as the cases of kerosene oil drop down, we see an increasing trend of ingestion of pharmaceutical agents from paracetamol to ibuprofen to antidepressants and so on. And plants and pesticides also common in rural areas, and the overall mortality compared to 100 cases, mortality is around 0.4 to 0.7. So if you see about 2,500 cases, then you are likely to see about 20, 25 mortalities. And notable reductions have been observed with regard to the harmful first aid practices or the harmful remedies by parents over the years because of the increased education level of parents of our country. And we see a bimodal or 2 peaks in children when it comes to the incidence of poisoning. The first group is the toddler group, where we see most cases of accidental poisoning, and they occur within the home premises. Most of the time it is minimally toxic, and it happens due to the exploratory inquisitive behavior. They just explore and then test with certain pill, unless you ingest quite a bad pill, which can be quite toxic with a smaller dose. Most such children will not have a bad outcome. Most of them can be discharged. However, when it comes to adolescents, because of their deliberate ingestion, they might take a toxic dose or a high dose that can result in significant mortality or morbidity. And also in the adolescent group, we see now there is a massive increasing trend when it comes to recreational drugs. It's like the iceberg. They're not reported, but it is quite a serious problem that we see nowadays with an increasing trend. And so what are the differences between children and adults when it comes to anatomical and physiological considerations that are very important in making management decisions? In children, the volume of distribution is low in younger children, and it increases as they age, which means there's a higher tendency that the drug or whatever the poison can accumulate in the blood, resulting in a higher toxicity in younger children. And smaller children have a bigger body surface area, so and also they have thin skin, so dermal absorption may be faster in smaller children, especially when there's a risk of poisoning by the local agents such as acids, alkali. So burns can be quite extensive. And airway, they have a small airway. So when it comes to airway management in an emergency, as well as the bronchospasm with certain toxins, so the outcome will be worse because of their narrower airways. And renal functions, kidney functions in younger infants may not be, they are not mature, which means certain drugs that are excreted by the kidney or the liver tend to accumulate at a very high dose with the same ingestion compared to an adult. And breastfed children, certain drugs are known to be secreted, things like lithium, aspirin, and there can be mothers who are using substances. Again, it's a serious problem. Although one might think it's quite rare. I can tell you one of my research experience recently. I went to prison and studied mothers who have been addicted to drugs, and there's quite a number of mothers who are addicted to drugs. In that study, there were nearly 150 mothers who were admitted to the prison ward just over a period of 1 hour, one year, which means it's not rare actually. We see this problem in those confined environments. And certain pills, we have to be very mindful. Smaller doses, 1 or 2 tablets, injection of 1 or 2 tablets can kill such children, especially younger children who have low body weight. For example, a child who weighs about 5 kilos, 6 kilos, 6 to 7 months, with the exploratory behavior, who accidentally put inside mouth 1 or 2 tablets. Examples like tricyclic antidepressants, beta blockers. These agents can result in significant hypertension as well as cardiac arrhythmias, and can result in death because of the anatomical and physiological changes, as well as the tendency to have a higher per unit weight dose. They are likely to have a higher ingestion as well as a worse outcome. And opioids, theophylline, chloroquine, amphetamines, sulfonylureas, benophosphate, and digoxin, or oleander. So these agents, if ingested by a younger child, we have to be seriously concerned, and then we should anticipate the worst case scenario and then plan our management. And it's always good to, if you are not sure, always it's good to seek advice from experts as well as poison information centers for expert advice if you have a doubt about what to do. So general approach to managing any child with poisoning, we have to assume the time of ingestion as the latest time as possible, right? So that you have a good opportunity to give decontamination, right? So that's the importance of thinking in this way. So if you think like you can, if there is a doubt about the time of ingestion, and if it's 4 hours early, then there's limited place to activate charcoal. But if the parents are not sure about the time of ingestion, The good thinking would be to give a decontamination, because there's a chance that activated charcoal may be effective when the indications are present, unless no contraindications are present. And if there's a concern about child ingesting more than one drug, but the parents are not sure, or certain tablets are missed, then we should assume that all agents all agents undercounted or missing were ingested by the child, so that you can avoid that decisions of disregarding the risks that may actually be there. And spillage is also difficult to estimate, so we shouldn't go after thinking about how many syrup or the medication was spilled. We have to assume that the child has ingested all, unless we are very sure that certain amount of the syrup is spilled. And when more than one child has ingested drugs, then it's good to assume that each child has ingested all of the medicines that are implicated in the event. And if you are not sure, always think of consulting the Poison Information Center. And in our country, I'm sure you all know, we have a Poisonings Information Center based at the National Hospital of Sri Lanka. And I mean, it's good to get advice from the center if you are not sure about how best to act in an emergency. The risk now, they always come present as an emergency, where we have to make a quick decision about what to do, whether to give activated charcoal, whether to give an antidote, or whether to stabilize the airway breathing circulation. So these type of decisions we have to make. So before making that decision, one of the very important things to do is to perform a risk assessment. It's a very simple thing, but we need to know certain key information from the parents in order to make that decision or to perform the risk assessment. Identify what were the ingested agents. Knowing what tablets what syrups the child has ingested is very important. Child may present with the ingestion of salbutamol and theophylline, or salbutamol and chlorpheniramine, etc. And not only that, find out whether the child has presented with a standard, ingestion of a standard release, or sometimes there are extended release preparations. So knowing that is very important. For example, there are extended release aspirin tablets, which has a longer period of absorption. So if you're giving activated charcoal, even if the child has presented late, about 6 hours after, there is a window period where still you can administer activated charcoal because of prolonged absorption, and determine the dose of the drug, right? And then determine whether a child has ingested a toxic dose or not. That you can do by looking at the internet sometimes. But certain countries, we don't have a clearly established poison information website, but the UK, like if you see in UK, you can find out Toxbase, and in Australia there's another information center called TAPNA. So TAPNA and related their information sources. So you can but if you can just look up the recommended sources on the internet if you don't have access to these web sites, and then we can estimate whether a child has presented with an ingestion of a toxic dose or not, and then try to determine the time since ingestion. It's again very important. That is to determine whether there is an opportunity to give gastric lavage or activated charcoal to a child to prevent absorption of the drug. And then take a quick set of observations. Note down the pulse rate, respiratory rate, level of consciousness, pupil size. All of these are important because a child may be completely asymptomatic, whereas the other child may be symptomatic, presenting with a abnormal heart rate or respiratory rate or deteriorating consciousness, which are useful in making a rough differential diagnosis, thinking of what the likely agents are, right? And then we'll talk through these toxidromic features. These observations are quite useful. With the knowledge of the toxidromes, we can narrow down what the likely ingested agents are. And then again ask a few questions from parents about the child's weight and child's age, as well as if they have any comorbidities like liver or kidney impairment. Because if there is a liver or kidney impairment and a child comes with a drug that is predominantly excreted by the kidney or liver, then that child will have likely to have a worse outcome compared to those who have intact kidney or liver functions. So in physical examination, note down the vital signs, level of consciousness, pupil size. It is again important. For example, if a child has presented with ingestion of organophosphate, then they have pinpoint pupils. Or if they present with a plant poison like Actana or Datura or atropine, then they can have the opposite. And skin signs, whether they have a hyperemic skin or a dry skin or increased sweating, again, it's important in determining the likely toxic agent. And this is, this slide shows how you can make use of your observations to narrow down, right? But we don't need to know all of these, right? That's why there are poison information services, poison information sources. So what you have to do is to record the observations correctly, and then you can look up to those information sources and then try to narrow down. For example, if a child is presenting with increased respiratory rate, certain agents like salicylate, glycol, methanol, and recreational drugs can be the cause. Whereas if a child is presenting with bradyapnea or respiratory depression, then the likely ingested agent may be a benzodiazepine, like a diazepam, or opiate. Opiates, remember, they're used by teenagers as an abusive drug as well. And heart rate, so tachycardia may be seen with certain poisons, whereas bradycardia is seen with the others. And blood pressure can be, high blood pressure can be seen with sympathomimetic toxins, whereas hypotension can be seen with antidepressants. And temperature, certain ingestions such as barbiturates or phenobarbital ingestion can cause hypothermia, whereas ingestion of recreational drugs or Actana or Datura or the anticholinergic agents can result in hyperthermia. So similarly, noting down the level of consciousness or the GCS is important. Certain agents like oral hypoglycemics, antihistamines, commonly we see chlorpheniramine, and various antihistamines, sedative antihistamines, opiates, they can affect the level of consciousness. And when it comes to pupil size, constricted pupils can be seen with organophosphate or opiate ingestion, whereas dilated pupil can be seen with anticholinergic agents, tricyclic antidepressants.
Hello.
Sir, we can't hear you.
resuscitate the child, whether you are the general practitioner or the family physician. If there's a chance to save life, as a doctor, we will have to resuscitate the child, and they might present to any doctor, to the general practitioner, family physician, anybody, to the hospital or to the paramedics. They might call an ambulance. So learning to resuscitate is an important skill for anybody, any health professional. um, so there are instances where we have to pay attention more on airway, when the child has presented ingesting agents like CNS depressants, diazepam, opiates, cholinergic agents like organophosphate. And then breathing can be problematic when they ingest agents like benzodiazepines, opiates. Circulation can be compromised if they present with ingestion of beta blockers. And some toxins or some poisons can cause convulsions. For example, glibenclamide, the oral hypoglycemics, can present with a hypoglycemic convulsion, and hyperthermia can be resulted from ingestion of agents like athena, that can result in anticholinergic syndrome. And nowadays, a lot of adolescents are, we see an increasing trend for adolescents to being diagnosed as depression. So depression, you keep them on sertraline, and we see many children presenting with ingestion of sertraline and other antidepressants. And serotonin syndrome is one of the toxidromes that we see after an intake of overdose of sertraline or SSRIs. So they can present with hypothermia. So looking at this vital signs is very important when they present with a possible ingestion, and if they have an unexplained fever, which is not actually a fever, which we call hyperpyrexia, which is a useful clinical sign in diagnosing the underlying agent. And decontamination, so it's again important in children as well. Here, the key message is, children, they don't like to take activated charcoal because of its bad taste. What you can do is you can try mixing it with a flavor. And what we do in our settings is we mix it with yogurt. We mix with some yogurt. That will increase the compliance as well as likes to increase the final outcome as well. However, we have to know the indications as well as contraindications clearly. If you are administering activated charcoal to a drowsy child, airway must be protected. And sometimes there are indications to administer multiple dose activated charcoal for drugs with a prolonged absorption time, like extended release aspirin, theophylline. When ingested by a child or a teenager, you can consider administering multiple dose activated charcoal. And also know that certain drugs or certain toxins are not absorbed to the charcoal, so there's no effect, and better to avoid. Examples like iron, lithium, and organophosphate. So we have to be careful not to administer any activated charcoal. And activated charcoal is contraindicated in certain instances, because instances like bowel obstruction, GI hemorrhages, as can happen following ingestion of a very high dose of iron, that can cause GI hemorrhages. So if we administer activated charcoal to those with GI hemorrhages, that can go into peritoneum and result in a significant chemical peritonitis. So better not to administer and know that they are contraindicated. And gastric lavage is not frequently used nowadays. There are only few indications, and we can use it for agents where activated charcoal is not effective. Agents like lithium and iron, they are not absorbed to activated charcoal, so you can use gastric lavage if they present early, preferably within 2 hours. You can try a gastric lavage. However, that has to be carried out with adequate airway protection. If you administer it to a child with who is drowsy, then it can lead to aspiration. And with certain substances like acids and alkali, Administration of any decontaminating agent, including charcoal or gastric lavage, is contraindicated because these acids and alkali can spill over into the lungs, resulting in a severe chemical pneumonitis. And sometimes there is a place for whole bowel irrigation as well. It's not commonly practiced. Uh, Indications include a child presenting with a severe overdose of iron or lithium, where lavage may not just be enough. And at the time of absorption is somewhat later, so some of the tablets can go further into the GI tract, so just lavage may not be effective. So for such children you can do whole bowel irrigation. And the other indication for doing whole bowel irrigation is, there have been cases, while I was doing the foreign training. We discussed all the safeguarding cases. So one child actually was a drug trafficker. They're from a very chaotic family backgrounds, and drugs are more of a problem there as well. So they used to pack these drugs as packets, and they swallow it. So for the medical legal purpose as well as for the management purpose, a CT was then what you found was this multiple drug packets, and these people are called body packers. So in such instances, you can practice whole bowel irrigation. And after you do the risk assessment as well as attend to resuscitation, then you can, the next steps are to offer supportive care and investigations. Most children, they don't present with severe overdose. Uh, so it's very important to first do the risk assessment and then rule out the need for resuscitation. So other children, you can manage with investigation, simple baseline investigations, and some supportive care, and with a period of good observation. So what are these investigations? Blood sugar and ECG are commonly performed in our setting, but in UK and Australia, any child coming with deliberate ingestion, it's a standard practice to do paracetamol level and ibuprofen level, because they are quite common there as well. However, we don't have facilities to do paracetamol levels and ibuprofen levels. So what we can do here, blood sugar and ECG. And other investigations are not always necessary, and then they have to be decided based on a kind of individual basis. If a child presents with severe vomiting after ingestion of a certain toxin, you can consider doing electrolytes. If you have facilities, you can do a blood gas. And if somebody presents with the ingestion of lithium or iron, which are radioactive substances, then you can do X-ray and see. Or if a child presents with the coin ingestion or button battery ingestion, which will be visible on the X-ray, then you can consider doing an X-ray abdomen or a chest. And for those teenagers who are presenting with the ingestion of abusive drugs, we have the facilities to do urine toxicology screens. So agents like opiates, benzodiazepines, barbiturates, so they can be detected. They can be detected in this toxicology screens. So they are helpful not just for management, but also for medical legal procedures. And a little bit about the antidotes. This may not be available in every center or every place we work. So these agents are available in tertiary centers with specific tertiary care facilities for management of poisoning. But just know certain agents have antidotes. So if they are there, then it's good to arrange transport of these children to those centers so that these antidotes can be administered. If you take beta blockers, if they have a cardiac arrhythmia, then you can treat with atropine, insulin as an inotropic agent, glucagon, and carbon monoxide. It can be a presentation. It's not so common, but if there's a house fire scenario, or when there's a gas leak, then children can, or if there is a kind of vehicles, when a child is locked inside a car. So, such scenarios, a child can present with carbon monoxide, then oxygen indicated, hyperbaric oxygen sometimes, cyanide, not very common, but hydroxycobalamin is the antidote, digoxin, digibind, then ethylene glycol, ethanol, iron, bisphoxamine, methanol, ethanol, then opioids, naloxone, organophosphates, atropine, and palindroxamine, paracetamol, NEC, or the N-acetylcysteine and methionine, then sulfonylureas, octreotide, tricyclic antidepressants, sodium bicarbonate. So know that there are certain antidotes available in tertiary centers for specific management of this group of children. And most of the time, this poisoning event, especially accidental poisonings, will not result in a significant mortality or morbidity, right? So most of these children can be discharged after a period of observation. So it's very important to do the risk assessment and then decide what type of observation or what type of supportive care a child will need. So most children who deemed at no risk or very trivial, limited risk for having problems can be discharged after a period of observation up to 24 hours. However, children with symptoms or evidence of intoxication, then they will need to be observed until they are out of danger. And safeguarding again is very important when it comes to poisoning in children. So always consider the possibility of safeguarding. There may be an element of negligence. For example, parents might leave pill boxes not properly closed, so that younger children have easy access. So what we do here is, when they come to a hospital after you managed and then about to be discharged, we educate the parents about the consequences of this, as well as we educate the public health midwife or the MOH, and then the public health midwives will go and pay a visit to this house to find out whether there are any risks for the child's safety, and then provide necessary advice. So which is a very good step in the prevention at the community level. And sometimes this can be of medical legal significance, where a parent might intentionally give a poison and then seek medical attention. That is common in developed countries, where you do this and then you become eligible for social benefits. So they have medical legal implications, and so it's very important to investigate in detail into such cases to find out the safeguarding concerns relevant to a child. And poisoning and deliberate self harm. This is mostly a problem with teenagers and all children, like under 17 years, teenagers presenting with deliberate self poisoning will need careful evaluation by a psychiatrist. And then, if problems are identified, we need to give ongoing support from the psychiatry or the psychology team. And we did a recent study about children with deliberate poisoning. There is a very strong association. We noted a very strong association having an underlying psychiatric problem, depression, and then child having this act of deliberate self-poisoning. So most of these children may have depression. So it's very important that they are assessed properly by the psychiatrist or the psychology team to identify underlying depression and then arrange follow-up. So let's look at briefly about important and very common poisons that we encounter in children and teenagers. Paracetamol, it's the most common agent that is seen among adolescents. The toxic dose is over 200 milligram per kilogram if it's a single overdose, but it will be about 150 milligram per kilo if it's an ingestion had happened over a period of 48 hours or more. So what happens with paracetamol? It's absorbed in the gut and then reaches to the peak concentrations about 1 or 2 hours. And most of the time, at the physiological levels or at normal, like therapeutic doses, paracetamol is metabolized by glucuronidation and sulfation. However, when P450 enzymes um, are saturated and the glutathione stores are all used, then the child or the person who has ingested result in producing an toxic intermediate, which is called NAPQ, N-acetyl P-benzoquinamide, which is quite hepatotoxic. So affected patients can develop significant liver toxicity, including fulminant liver failure. The markers of injury, paracetamol levels, and the ingested dose. So in our country, we don't have paracetamol levels available unless in a few centers in private sector. So we always go by the paracetamol dose. And then late markers are liver function. So no point in doing AST, ALT as to identify the early toxicity. So we use them only as to determine when to stop the neck infusion, the liver functions. Otherwise, we always go by the dose. And activated charcoal is an important treatment option, which has to be administered within 2 hours for syrup and within 4 hours for tablets. And antidote is the N-acetylcysteine. Or if it's not available, we can use methionine, which is cheaper than N-acetylcysteine, and it is administered as oral, whereas N-acetylcysteine is an IV infusion. And we have to monitor the child's liver functions, mainly ALT and INR. And if you have facilities, paracetamol level, and then be guided by those test results to determine when to stop neck infusion. If you have paracetamol levels, we can use this nomogram. Um, Most of the developed countries, that is how they manage. They go by the nomogram. However, if we don't have the nomogram, what we can do is we can go by the ingested dose. Although a single dose of 200 milligram per kilo is considered the toxic dose, practically, College of Pediatricians as well as College of Physicians both agree that a dose of 150 milligram per kilo is considered the toxic dose, because we have seen patients developing evidence of significant liver toxicity even after ingestion of a dose of more than 150 milligram per kilo. And if they present with this dose ingestion, but if the child or the patient remains asymptomatic, then you don't need to start NEC. However, if the patient is symptomatic, then you have to start treatment. And if the child presents within 4 hours, always consider giving activated charcoal. For syrups, consider giving it within first 2 hours. If the child has presented late after 4 hours but has ingested a dose of more than 150 milligram per kilo, then it's good to do the baseline ALT, PETNR, and then start with the NEC infusion. NEC infusion now administered as a 2-bag regime to make the things less complicated. And then towards the end of the second bag, that is at the 18th hour, it's recommended to repeat this ALT and INR. And you have to be guided by the ALT and INR. So as far as they remain high or there's a rising trend, it is recommended that you commence a third bag as well. And if the liver functions dropping and there's clinical improvement, then you can consider stopping the NEC infusion or methionine. And salicylate, it's again a toxic agent. In children, they might lick this methyl salicylate balms because of its taste, its smell like menthol, because methyl salicylate always combined with menthol in certain applications. So children tend to taste it, or children tend to smell it and then explore it. However, methyl salicylate is even more poisonous than salicylate when an overdose is ingested. Especially methyl salicylate is very concentrated compared to oral salicylate. So a little bit little amount can result in significant toxicity. So what it does is it uncouples the aerobic respiration, Krebs cycle, and thereby it activates the anaerobic metabolism, resulting in accumulation of lactic acids and significant metabolic acidosis. And there can be compensatory hyperventilation, respiratory alkalosis. It is just a marker of toxicity. Salicylate has a prolonged absorption time in overdose. The gastric transit time increases significantly. So there's a place for gastric lavage that can be administered up to 4 hours after ingestion. And multiple dose activated charcoal also can be considered for sustained release preparations like sustained release aspirin. And we don't have facility to estimate salicylate levels. And what we go by is by doing a blood gas. So if there is evidence of metabolic acidosis, the recommendation is to give IV bicarbonate, IV sodium bicarbonate in 5% dextrose, aiming for a urine pH of more than 7.5. So what you monitor is the urine pH to keep it just above 7.5 to have an alkaline urine. So with this alkaline urine, salicylate known to be excreted faster. Thereby you try to get rid of the toxin. However, if there is significant toxicity, sodium bicarbonate alone may not be effective, and such children need expert care, including hemodialysis with involvement of the nephrologist and intensive care team. Yellow oleander or Kaneru, again, a major public health issue in our country. Even now, it's a major health issue. If you go to Batiklu, if you go to Anuradhapura, you see a lot of adults presenting with oleander. But also there are children who are presenting. I did a study about 10-12 years ago in Anuradhapura. There were many interesting stories where children presented with ingestion of Kaneru. In one instance, the family had very a lot of financial hardships, and the father had mashed Kaneru and then I think made a curry or something, and then shared with all the family with the intent of dying and so committing suicide as well as homicide. So there can be instances. These plants are grown even in Colombo and suburbs. These plants are grown as an ornamental plant, and it can be found with other nice looking plants. Kaneru also is there, and a child might explore these beautiful flowers, and the seeds might explode and then can result in an unexpected poisoning. But when you take a toxic dose, their pharmacokinetics differ. It's very hard to predict what will happen. Therefore, these children need monitoring for a prolonged period, up to 48 hours, with continuous cardiac monitoring, because there can be delayed toxicity, no specific test to diagnose, and treatment is often expensive and include things like digibind and cardiac pacemakers, which are not available everywhere. So management is quite complicated. How it causes toxicity is by inhibiting the cardiac sodium potassium ATPase. With that, there is intracellular accumulation of calcium. Therefore, we have to avoid calcium in the treatment. We may have to correct the electrolyte imbalances, and we will have to correct the cardiac dysrhythmias. Common ones include bradyarrhythmias, heart blocks, and if there are, it's very much essential to monitor these children for at least 48 hours, the symptomatic children, and with regular ECGs to look for types of heart bradyarrhythmias. And then if it persists, then we will have to go for atropine as a bridging agent, followed by cardiac pacing. Digibind is available but at the moment it's not available in Sri Lanka, and it's quite expensive as well. So patients are managed mostly with cardiac pacing, atropine, and decontamination with multiple dose activated charcoal. Investigation, so cardiac monitoring is a must for up to 48 to 72 hours, and you have to monitor the electrolytes, especially the hypokalemia. Other countries, they monitor digoxin levels, but we don't have facilities, and it's quite expensive, and it's not very useful as well. And Datura stramonium or Dattana, it's again a common poisonous plant seen in rural areas. The main toxic effects are due to the anticholinergic effects. It has atropine as the poisonous substance, so that will lead to symptoms of anticholinergic toxidrome that will include dry mouth, double vision, hot dry skin, increased heart rate, increased temperatures, delirium, coma, and so on. So all plant poisons, there is place for activated charcoal and gastric lavage, and the toxidrome this plant causes is the anticholinergic toxidrome. So it can cause delirium. So delirium can be managed with sedation, IV diazepam. It causes hyperpyrexia. So active cooling may be indicated, and the antidote is physostigmine. And Behet tenderu is the other plant poison that is again seen in rural areas. What it does is it inhibits protein synthesis when you take an overdose. And it has significant GI side effects. The affected children can present with hematomesis, melena, significant vomiting, diarrhea that can result in hypovolemic shock. And some children will have other complications like coagulopathy, pulmonary edema, and organ failures, and so on. So management is supportive. So you can try activated charcoal. If there is hypovolemia, we will have to resuscitate with fluid resuscitation. Might need respiratory support. And as it causes organ failure, so organ-specific support may also be needed. And kerosene oil is the most common type of poison, accidentally ingested poison among younger children. However, most of the time it doesn't cause significant mortality or morbidity. There can be some respiratory symptoms, and most children can be discharged. But if there's a significant ingestion, it can be toxic to the lungs, and it can result in a chemical pneumonitis, pulmonary aspiration. However, because it is a liquid hydrocarbon, activated charcoal or gastric lavage are contraindicated. And some of the clinicians use steroids and antibiotics empirically, but there is no place for such use empirically, and there is no proven benefit as well. Ethylene glycol is a different poison that can be found in vehicle coolants. And it can be mistaken for a drink because these coolants are stored in mega bottles or drink bottles. So child might think that this is a drink and then accidentally drink. But it is a significant poison that results in a marked metabolic acidosis with a high anion gap. And activated charcoal is not going to be effective. And the antidote is the ethanol in case of methanol ingestions. And the ethylene glycol ingestion, the antidote is the ethanol. And iron is a commonly used drug by most women or mothers of childbearing age. However, it can be poisonous as well. It can cause gastrointestinal hemorrhages, circulatory shock, convulsions in significant overdose. And the antidote is desferrioxamine. And this X-ray shows evidence of iron tablets deposited over the GI tract. And this is again a common thing that we see in teenagers. If you look at the deliberate salt poisoning events in teenagers after paracetamol, so paracetamol is certainly the most frequent poison, accounting for over 50%, but there is at least about 7-10% of teenagers presenting with ingestion of antidepressants, and sometimes they are diagnosed with depression. That's their own tablets, or maybe one of their parents or one of their siblings is diagnosed with depression. But it is a significant poison in overdose. It will inhibit the cardiac sodium channels and result in serious cardiac arrhythmias. Not only cardiac toxicity, it also has alpha adrenergic and muscarinic blocking effects, resulting in anticholinergic toxidromes, as well as direct cardiac toxicity. So this is an image of a child presenting with tricyclic antidepressant poisoning that will lead to broader complex or the ventricular tachyarrhythmias, which is the most common toxic effect. Because it blocks the cardiac sodium channels, your first line treatment is again the sodium bicarbonate, because tricyclic antidepressant goes and competes for the sodium channel with sodium. So what you have to do is you have to increase the sodium. And so you give it as sodium bicarbonate, and this sodium competes with the TCS, and then try to dislodge TCS from the sodium binding channels, thereby alleviate the sodium channel blocking effects. So the treatment is IV sodium bicarbonate. And button battery is again a pediatric specific thing, not seen in adults. Children might ingest accidentally these batteries, which can be found in calculators, toys. And the thing is, if you ingest and if it's stuck on the upper gastrointestinal tract, somewhere in the esophagus, it can actually erode into the esophagus and then result in fatal hemorrhage. It can erode into the descending aorta, it can erode into the trachea and result in a tracheoesophageal fistula. Kind of a serious complications can happen. However, if this button battery is able to go passing the stomach, then we don't need to worry. It is no longer, the child is no longer at risk, and then you can just expect, advise the parents just to keep looking at the stools for the next 1 week or so, and then to make sure that the button battery has passed out of the body in stools. But so if a child presents with a suspected button battery, so first we have to do is we have to do the X-ray chest, neck, and the abdomen, and then locate where the button battery is. So if the button battery is above the level of the diaphragm, then you have to do an urgent endoscopy to retrieve it. But if you see the button battery below the diaphragm into the stomach or further down, then you don't need to do any invasive procedures, and you can reassure with a follow-up plan just to make sure the child, this button battery has gone out of the body with stools. And there are a few less straightforward presentations. For example, a child might present with neurological symptoms, deteriorating level of consciousness, or a child might present with altered behavior with no obvious cause, or sometimes a younger person or a teenager might present with quite agitated, delirious manner after ingesting a recreational drug. So these are again presentations, toxicological presentations that you might encounter in children, and they encompass this broad group of clinical toxidromes. So this is the last bit of my kind of presentation. So I'll touch kind of superficially on what these toxidromes are, because that is helpful in narrowing down very complicated poisoning presentations to very simplified differential diagnosis. However, in doing so, we have to also think of other medical causes. For example, child with drowsiness, it can be due to a meningoencephalitis, or it can be due to a metabolic crisis, or it can be due to an intracranial hemorrhage or septicemia, severe infection. So we have to be mindful of these possibilities as well while thinking of toxidromes. So let's see what they are. If a child presents with drowsiness, it's good to look at the type pattern of breathing and the pupils. So if the pupils are pinpoint, and if there is bradyapnea and drowsiness, so that toxidrome is recognized as opioid toxidrome. So the likely agent is the likely agent is the opioid agent. The importance of knowing this is like the antidote is naloxone. So if you can see this triad of pinpoint pupils, bradyapnea, and drowsiness, and confirm the opioid toxidrome, and if you give naloxone, then you can quickly recover the child, because opiate has a very short T half, so the toxic effects are rapidly reversible upon administration of naloxone. And if you have these symptoms and signs plus hypotension and bradycardia, the cardiac depressants events, then you have to think of opiate generally doesn't cause it, but the sedative toxidrome does cause it. So examples include diazepam, alcohol ingestion, and sometimes chlorpheniramine also they are also in this group of toxidrome, but they are not very much known to cause cardiac side effects, but they can cause other presentations. And then you can decide that what the child needs is the supportive care. And a cholinergic toxidrome or the organophosphate toxidrome is recognized when you have more cholinergic symptoms, that is diaphoresis, lacrimation, urination, diarrhea, bronchuria, vomiting, a lot of secretions, all the secretions. So child is covered with secretions everywhere. So that is due to the cholinergic toxidrome. Then your DDs are organophosphate or carbamate. So then you can go down that line of management. The opposite, anticholinergic toxidrome, can happen with tricyclic antidepressant ingestion, or atropine ingestion or datura ingestion, right? And phenergan, antihistamine ingestions. And these they have the opposite of what the children with cholinergic toxidrome have. So they have dilated pupils, hyperactive bowel sounds, urine retention, dry skin, tachycardia, hypertension, hypothermia, and so on. So there, the management again, supportive care. And there is a group of children or the teenagers that are known to present with sympathomimetic toxidrome. So where they have a lot of sympathomimetic effects. How you differentiate anticholinergic from sympathomimetic, or I have put in red. Anticholinergic, they have a dry skin and hypoactive bowel sounds, whereas sympathomimetic toxidromes, they have increased sweating and increased bowel sounds. But other symptoms, all they are shared by the both toxidromes. So etiological agents for sympathomimetic toxidromes include recreational drugs, which are commonly used by teenagers, cocaine, amphetamines, MDMA, right? So if somebody presents with sympathomimetic toxidrome, then we have to think about possible ingestion of a recreational agent, right? So this picture summarizes, in a very graphical way, what these clinical features are. So the messages I want to convey is, it's very good to know about the risk assessment. Risk assessment is very important for any clinician to decide quickly on the likely needed action, whether to resuscitate, whether to observe, whether to discharge. So that is based on accurate risk assessment. And while suspecting toxicological emergencies, it's also be mindful, good to be mindful about other medical DDs like meningitis, meningoencephalitis, septicemia, metabolic causes, especially in children who are presenting with doubtful poisoning. And safeguarding concerns also we have to keep in mind, especially when they present with incompatible history, and so on. And children with deliberate self-poisoning, always they need referral to a child psychiatrist. And then if they are found to be having some underlying psychological problem, they need to be followed up, because later on they can present with a committed suicide. So the whole, the practice should be, aim to prevent such instances. So it's very important that all of them are followed up. And prevention and parental education also play a significant role in reducing the pediatric poisoning cases. So if if you encounter a poisoning event, it's good to get in touch with the prevention arm, that is the medical officer of health and the public health midwife, so you can notify and then arrange, some kind of, for example, public health midwife visiting the house. Now, in certain countries, these poisoning events are notifiable. We still have not made it notifiable, but it's very good for epidemiological purposes and mapping and finding trends, as well as the prevention, planning or preventive acts. So ideally they have to be notifiable so that they can be prevented. So thank you very much. So I'm happy to answer any questions if you can ask.
So we have some questions in the chat box. First question is,
Okay.
in paracetamol poisoning, how can we define the hepatitis with relation to liver enzyme levels?
Sorry, I didn't get the question. With regard to timing.
In paracetamol poisoning, how can we define the hepatitis with relation to liver enzyme levels?
Hepatitis, right?
Yeah, hepatitis.
Yeah. So yeah, the concern is whether child will develop fulminant liver failure or not. However, the liver involvement, it's not actually hepatitis. Liver involvement is identified by doing liver function test, but they are not early markers. An ALT is the one that is specific for paracetamol poisoning, alanine transaminase. So ALT value of over 50. They are not very high, over 50, and INR of 1.3. They are the cutoffs. So when you are about to finish the neck infusion, right, or methionine uh, administration, you will have to do these investigations after the baseline one. So baseline, repeat when you are closer to stop the infusion. So if you see a rising trend in ALT or INR, rising trend, the recommendation is to continue continue for another, like that's the third bag. Now, previously we used to give 3 bags, that is for 1 hour, 15 minutes, and 20 hours. But now what is practiced is you give 1 bag for 4 hours, the second bag for 16 hours. There is no kind of 1 hour, 15-minute thing. So first bag for 4 hours, second bag for 16 hours, right? But if you see there's a rising trend of ALT or INR, then the recommendation is to start the third bag of 100 milligrams per kilo.
There is another question about paracetamol poisoning. Does Ramak-Matthew nomogram used for calculating toxicity or deciding treatment starting and endpoints?
Yes, but there are certain instances now we can't use it because we don't have paracetamol levels in Sri Lanka. So we don't use it practically, but it's used elsewhere in Australia or in UK. If you go and practice there, then you will know that is used. Every child coming with, every teenager coming with possible ingestion, you do paracetamol level and acetyl salicylic acid levels. So it's a quite useful thing to identify the toxic dose, because they don't go by the toxic the milligram per kilo dose, but rather they go by the paracetamol level. So you do it at a paracetamol level at 4 hours and then read it at the chart 4 hours after ingestion. And if your value is above the treatment level, then you start with NAC. And the treatment endpoints are again paracetamol level above 10 and INR and ALT. So we don't use it, but even for them, there are instances where you can't use the nomogram, especially when you present with repeated supratherapeutic injections or a delayed presentation, and where the injection time is not known. So in such instances, the clinician is not able to use this chart. Then they have to go by the clinical ground symptoms, ALT, and the INR to decide the need for an acetylcysteine.
Okay, sir. And there is another question. What is the management for ingestion of silicone gel that we put to peanut packets as a moisture absorbent?
What is it? Sorry, which one?
So it asks about that silicone gel packets which are inside peanut packets. So what is the management?
Silicon. Yeah, silicon, the desiccant, right? So I have got calls for this thing, but it's not a toxic, it's not a significantly toxic substance. What you need to do is to observe the child, observe the heart rate, respiratory rate, and the basic observations, and then observe for a period of time. Charcoal administration is not recommended either. And generally, it's considered not seriously harmful.
Okay, sir. And there is another question. What is the time window to do urine toxicology testing?
Oh, again, that's a good question. It has to be done as fast as you can because certain agents rapidly clears rapidly clears. Uh, so it has to be done. Uh, uh, it has to be done as fast as possible. But the thing is, you don't get the results back quickly. You can do it, you can do it then and there, but you don't get the results quickly. So the point of doing these tests, from the management point of view, to get the results and then decide on the management, but they are not very much useful for management because they are not they are, most of the time they are not, the results are not back within a short time period. However, for the medical legal or the legal purposes, um, you have to do it as early as you can, and then when the results are back, then you can, you are, you can, that happens with, uh, legal kind of, what do you call this, recreational drug injections in sports medicine. So in such scenarios, to make a diagnosis, they are good, but there is a limited place for making management decisions in an emergency.
So the last question is, what is the dose of activated charcoal?
Yeah, dose of activated charcoal in children is 1 gram per kilo. So if uh, generally it's considered the 10 times the dose of the poison, but the pediatric dose is 1 gram per kilo.
Okay, so it seems that we have come to the end of the questions, and I think we can wind up the session for today. So I thank you, sir. Thank you on behalf of the Sri Lanka College of Specialist Family Physicians. And I thank you all for participating, and let's meet again in another CPD session. Thank you. Good night.
So thank you very much. Thank you very much for listening, and I hope all of you gathered some knowledge to your practice, and it might be impactful in future for your practice. So thank you all for listening.
Thank you, sir.